There's a buzz around you guys today. I can feel some tension, some palpable tension.
Yeah.
I got some news. I'm the last to hear everything, but you guys got some news about your phase 2 assignments or something? Or it's a lack of phase? Welcome to iPad. What did they tell you? You're just gonna find out later? Yeah, so I've heard that one too, but yeah. So you guys gonna go home now. See ya. It's not gonna happen. There's gonna be slots for you guys at phase 2. Don't worry about it. We're here and now. We're living the now. We're fighting the fight. That stuff will take care of itself. I know it's annoying though, because you guys are trying to plan your lives and figure that out. So, who came in here? Was it Major Kelly? You guys throw like rotten food at him or anything? 6:30 this morning? What did I miss? Oh my God. It's disgusting. Yeah, there's the night wait, by the way. Oh, that's exciting. Well, I don't have the prolific words of wisdom yet on that one. I'm just going to tell you that it's going to happen. It happens every class. I will tell you, and again, I'm saying this not to try to bail or, support my colleague, or, I'm glad his message, he told you guys, that's one thing that's positive. But when I was out at phase 2, West Point, like 2 of the folks that were getting ready to finish, like pretty damn soon, like this week, hadn't received their orders yet, and I was like astonished. I was on the phone trying to call HRC for them. Yeah, so that just sucks. I mean, that's just professionally embarrassing from the SP Corps. That's all I got for you on that one. Yeah, I don't know if I don't know if somebody quit, if somebody retired, if we like just didn't track it or what. But yeah, they were. I'm like, hey guys, tell me about phase 2, and they're like, screw phase 2. Like, we need phase 3 orders. So I'm like, I don't have anything to do with that, but I'll try to make a call. When do you guys leave next week? I'm like, oh my God. Like, they're trying to go to Bolick. One kid was trying to go to Bolick and return, and then go to his follow-on assignment, but had no orders. It was just insane. I remember, and I played them. I still have the voicemail from HRC when I finished phase 2, and they'll have you guys fill out this dream sheet of where you want to go. At that time, I was like bright-eyed and believed that the Army cared about me. I was like, I love the Army too. This is such a great relationship. Things have changed. But so I filled it out, and then I was like, oh man, I haven't heard anything. Graduated, so happy I graduated on cloud 9, and I get a voicemail from HRC, and it's like this 2-minute voicemail. Dude's just rapping away. Oh, Captain Rogers, like, hey man, congrats, appreciate all your hard work. I see you finished, top 3 in your class. Like, I see you put, he just goes through 1 through 5. And he's like, yeah, we're not going to get you there. Those are really high spots, high demand spots. And I forget where I put. Oh, I was asking to stay at Fort Stewart, so it wasn't anything like, I wasn't asking for the moon. And he said, we're going to send you to Fort Riley, but don't worry, that's a desirable spot too. And I'm like, where's Fort Riley? And I saved the message because I just laughed so hard, and I was like, the Army's a mess, hot mess. But he's still in. He's an 06 now. If I ever find him, I'm going to play his voicemail. I'll be like, this is how you deal with people. It'll happen. I'll keep my ear out for y'all. I'm like I'll just tell you guys whatever I hear. If it's a disaster and we're going to hit the wall, I'll let you know. I say we. You guys are going to hit the wall. I'll be on the sidelines coaching you guys. Like, brace for impact. Brace for impact. Speaking of, I think, did I have you guys yesterday from like 3 to 5? Did I tell you my old man got in a car accident yesterday? I did. Did I tell you the message I got from him? That was so insane. 75, losing his marbles. But I get home and I talk to him. He's fine. He just plowed into somebody. He's like, Dad, what happened? And he's been slowly declining. I told you he forgot his pants mailbox, but lost his wallet, lost his phone, and I talk to him all the time. He's in New Hampshire. He's like, I'm losing my mind. I'm like, yeah, whatever, dude. Like, I'm in Texas. Come on down, hang out. And he was going like 50 miles an hour, and just no brake, dude. Smashed into the lady, airbags deployed, hit his head, knocked himself out. No seatbelt. Because why would you wear a seatbelt? Matter of fact, this dude gets in the car when I go up there. He's a fat guy. Short, fat dude. Love him to death. And the seatbelt, all the cars now just beep until you put your damn seatbelt on. This dude takes his seatbelt, puts it behind him, and puts it in. Just shut the damn thing out. And I'm like, I'm just looking at him like, bro, now I know where I come from. You're my people, right? And I'm like, yeah. But just smashed into it. But he called me. He left me a message. And this is what kind of scared me, but I guess it rattles you a little bit. But as soon as he smashed into it, he picked up his phone and called me. Keep in mind, I got a brother and sister that live like 20 minutes from this guy. And he's like, help me. I need your help. Oh my God. I plowed into a car, and then I can hear this lady like, oh Jesus Christ. And like the best like Boston accent, like, what the fuck? And I'm like, how old are you? And he's like, 75. And I'm like, is this normal? And I was sitting on the couch watching Monday Night Football, missed it, didn't see that it came in when I was on the podium, and then I played it, and I was like, what the hell? So I just put it on speaker. My wife was sitting there, laying on the couch, and she's like, is that a real message? And I'm like, yeah, did I even tell you he got an accident? She's like, is he joking? I'm like, no, that's like serious. But he's okay. Refused to go to the hospital. Refused to go to the hospital. He said he had a massive, what he said, I got a knot on my head. Christopher is my name, but when you're from an Irish South Boston guy, it's Christopher. Christopher, I got a knot on my head. And I'm like, Dad, you should probably get checked out, like on Eliquis, of course, because he's old. And what else? He's like, I'm fine. He's like, I tore the skin. He's got like that old man paper skin. Get that crap away from me. But he's like, it's just my skin just tore off. So I just put it back down and wrapped it up. And I'm like, good job, Dad. You're slowly winning. I think he's losing, which is sad. All right, enough of that. So what do you guys? We got functional neuroanatomy. Oh, let me do something real quick. All over the place. Sorry, you guys are stuck with me. So. From yesterday. So what I like to do, I'll just go over some highlights from yesterday. Every time I look at you guys, it's crazy. So I'm not used to teaching the 2 classes. And so I see you guys, and it's very familiar from last semester, and I'm like, did we already talk about this crap? Like, I'm losing my mind, but now you know where it's from. So, all right, CT, when you guys are studying, there's a lot of slides. We try to distill the information. So if you're looking back, what do we have, like not this week, but next week is the exam, right? Next Friday? Yeah. It's fast. We got it. So if you're studying it, and like me, I had to go back and look at slides the same day just to make it stick. Go look at CT non-con. Okay, yeah, see, I put CT non-con and stable head trauma. We talked about CT non-con, but make sure that's something you guys are considering first. Stable patient comes in an MVA, they got a blown pupil, their vitals are normal. Where are we sending them? CT, right? If they're dying in front of you, where are we sending them? We got to do something to save them, right? So we're not like, oh look, they're blowing bubbles and they're like frothy and red. CT, we'll get that. Like they're gonna die over there. So complications at a lumbar puncture. So post-dural headache. Look at that. Chromosthetic reflex. Take a look at that. We talked about that a little bit. Always do a history and physical exam. That's easy money. GFR, kidney function prior to contrast. And then obviously a non-invasive brain study to look at activity. Anybody remember? EEG, yeah. I have no idea what that is. What's that? It's like that was like keeping score or something. All right, functional neuroanatomy. What do you guys think about when you hear that term? Functional neuroanatomy. Not everybody at once. I gotta hear from you guys. Nothing? The nerve? Listen, man, you can say whatever you want. You can say McDonald's, I'll be like, cool. Like, I don't know why, I'm just interested. But so functional neuroanatomy. Sensory motor function, good. CNS, PNS, not everybody at once. What about the back? You guys think about it. Neurotransmitters? Nice, that's a good one. Yeah. What else? Brainstem. Yeah. Different parts of the brain. Yeah. Yes. There's no trick up my sleeve. I'm just trying to get you guys engaged. Yeah. So almost 100% of these slides are stolen from your anatomy class. So if you guys see these and you're like, oh, these look familiar, they look like Nolan Wright's, or Dr. Wright, or whoever's teaching you guys anatomy, his slides. There. It's not plagiarism, it's collaboration. So, yeah. All right. And you guys are right. You're all right. I know sometimes, like, yeah, you just want to get on with it. You don't really want to play the game, and that's fine. But everything you guys just talked about is what we're going to talk about, right? So this lecture, although kind of dry, it is important because we're going to start mapping some of the parts of the brain, right? And remember we talked yesterday, define the anatomy, where's the lesion, what's going on with your patient, and this is going to kind of be the segue or the continuation of that, okay? So, very anatomy and some phys focus, but I think you've had most of this, so hopefully it's in there. We'll unlock it, bring it forward, and then we'll talk about what we need to talk about, and we'll go from there. Cool? All right. TLOs, ELOs, you guys can look at those. Someone already said it. So what does the nervous system do? In your own words, I know you guys can read.
Controls the muscles.
Yeah. Controls, receives, analyzes, makes a control, makes a decision. It's like we know what a tactical operations center is, or a TOC, essentially. So that's the way you have to army this thing out. You can do that, but yeah. So exactly what it says, right? So sensory receives external stimulation from the environment around us, right? Think about your afferent neurons. So it receives information from outside. Higher headquarters analyzes it, makes a decision, and then you act on it. So your motor efferent neurons. So I'm not trying to insult you guys. Broken down by CNS, PNS, right? CNS is the brain spinal cord, and PNS is everything else, right? It develops from the neural crest. We'll talk a little bit about developmental neural anatomy and why it's important. Don't memorize this. Tailor this for later on, and I'll tell you what the so what is at the end. But neurodevelopment begins at third week. Okay, starts with the neural plate, moving to the neural groove. The edges of the neural plate are called neural folds, and they turn into the neural tube. Mildly interesting. It is relevant, and I'll tell you guys why in a second. So, a little bit more. 3 layers of cells differentiate the walls and clothe the neural tube. You guys can see there, outer, middle, or inner. Thank God that's easy. Or you can remember a marginal, mantle, or ependymal layer. So, whatever you have to do to memorize that or kind of think about it. So. And then the neural crest is extremely important because that's going to differentiate into our the structures listed below, right? So dorsal posterior root ganglion of the spinal nerves, your spinal nerves proper, cranial nerves, so et cetera, and you guys can see that. Does that sound important, everybody? Yeah. So we'll get to the so what in a second here. So that tube closes at 26 to 28 days after conception, and you guys can see our problem there. So how is that all relevant to you guys as, because we're just making, primary care folks. There's a lot. We just flew through this, right? Like, conception, brain, fold.
Anything that they're exposed to during that time can be exposed to.
Absolutely. So anything they're exposed to can complicate or convolute that process right there. And it says it closes at 26 to 28 days, and you guys can see the problem there is pregnancy planning, right?
I don't even know.
They might not even know. And what are some things you guys can do as primary care managers to help plan pregnancy or help prevent neural tube defects, which is really what we're going to get into in a second. So. Or is there anything? What do you think?
Prenatal vitamin.
Folate, someone said? Yeah. So if you said alcohol, you're wrong. I thought I heard that. I'm like, PTOH? No. That's what you want to avoid. But folic acid, right? So somebody with B vitamin. So. All right, some neural tube defects to be aware of. So there are three major ones: anencephaly, encephalocele, and meningeomyocele. So anencephaly is failure of the anterior neural port to close. The cranial bones fail to develop and the brain degenerates. So you guys can see the distribution and how it's broken down, males and females. So. Myelomeningocele, also known as spina bifida, failure of the posterior neural port to form. That's most commonly found in the sacrolumbar region, about 80% except baby down there. So some of that formation is now outside of the body. There's one more we'll talk about. We'll talk about encephalocele at the end. I don't know why I put it there. It just happened to be there. So what? So these create a challenge or concern? Yeah, anybody know anybody with spina bifida? It's pretty prominent. Yeah. So you guys may not think you know somebody, but I guarantee you've seen somebody walking around that might have spina bifida. Maybe some lower extremity spastic movements or something. So maybe you haven't. I don't know. That's a bold comment to make. I know you have. I don't know what you see, but. All right. Folic acid supplementation decreases occurrence by 70%. It's pretty prominent. Pretty powerful statistic. So we need to know who needs it, who needs to have it, and what the doses are. So low risk, 0.4 milligrams of folic acid a day, and then if they're high risk, which we'll define 4 milligrams, so a little bit higher. So and those high risk are preterm pregnancies affecting by neural tube defects, either parent. And then we want to start the supplementation 3 months prior. So it's either 1 month for normal, low risk, 3 months for high risk. And a lot of this stuff, guys, like, again, I mean, it's kind of one of those things that's easy to remember, but prenatal vitamins have this thing mapped out, right? So if you guys are doing family planning, you will be doing family planning, like, no kidding. 18 to 35-year-olds, you're active duty, right? The folks that are outside, I can't say this emphatically, I don't know what you're going to do. I had somebody tell me at West Point, like, I just want to go do Botox injections, I'm not going to see anything. I'm like, cool, I guess, like, rock on with your bad self, right? So they'll be like, I'm not seeing this. My family care, active duty folks, you guys are going to be doing pregnancy planning. Okay, so prenatal vitamins has it for you, just got to have that open dialogue and conversation with your folks. Like if they're actively trying to get pregnant or conceive, it's probably a good idea that they take us. Okay? Too easy? Easy money. Is anybody like jazzed up when I said just to do Botox injections? Is that anybody's bailiwick? Yeah. Yeah? I ain't mad at you. I'm jealous. That's my mom does. My Mama Raj used to do that. So she's a nurse practitioner. She used to have Botox parties. They just make like 12 grand cash. Because you know insurance is not covering any of that, right? So they show up like all wrinkly and mushy face, neck deep cranks. You should probably stop smoking 5 packs a day, but whatever, just blast them up. And I walk around. Have you seen what movie is it when the dude's got all the Botox and he starts drooling? Is that the one? Yeah. Was it Ben? Who was the guy he was talking to? Was Adam Sandler?
It was Tim Allen.
And he's like, hey, man. Yeah, I'm going to find that clip and we're going to watch it. Because that's funny and that's what we should do. We should laugh. So this is just up to date, breaking out the dosage in case you guys don't believe me. So 0.4 for low risk, 4 milligrams for high risk, okay? This gets into some of the brain mapping. So the major parts of the brain, brainstem, cerebellum, small brain, diencephalon, and cerebrum are at higher headquarters, right? And we'll talk about each one of these. I know, deep breath, we'll get through it. It's exciting, right? This is the brain, damn it. This is good stuff. So, all right. So brainstem consists of what?
Medulla oblongata.
Come on, guys. Who wants to do it? Who wants to do it? Why are alligators so ornery? Mama says alligators are so ornery because they got all them teeth and no toothbrush, right? Nothing? Some of y'all. Water boy? Yeah.
H2O.
I'm guessing no? Yeah, that's a hard no? Okay, all right. You're wrong, Colonel Sanders. And he runs up and attacks him. All right, I've totally lost institutional control. So. Yeah, so it's going to be part, the Eula Oblongata, which is going to be aggression and fear. We'll talk about in a second. Pons, midbrain. We'll go over these in a second here. So, cerebellum, small brain. Talked a little bit about fine movement and ataxia yesterday, but now getting into kind of some of the mapping and how we look at some of the pathology a little bit later. Diencephalon, right, superior to the brain stem, comprised of the thalamus and hypothalamus. Yeah, I'm not going to ask you to Latin every breakdown of the word. So, cerebrum, right, largest part of the brain, higher headquarters, executive suite. It's where we make our decision-making process, right? All right, lobes of the brain. Y'all remember this? Frontal, temporal, parietal, occipital. Easy money. Mostly? Yeah. There's like bones that correspond to them. So you're like, frontal lobe is probably behind the frontal bone. Like, nice. Yeah. Maybe that'll be one of my new questions. I don't know. We'll see what happens. You won't do it. Maybe I will. Maybe I will. We'll see what happens. I'll just like to see if my colleague goes to review it. He's like, are you serious? I'm like, dude, it's a good question. It's a great question. All right, so we know that the left controls the right, right controls the left. It's divided up by the corpus callosum, right? So that's the only connection between the two. Sometimes you'll see, and they still do this, if you guys look up to like PubMed, like severe seizure disorders, refractory to medical treatment, they'll do a calosotomy where they actually cut the corpus callosum. I had a couple students ask last class, does that change their personality? I'm sure it does, and has second and third and tertiary effects, but if you're having such bad pathology that they need to do that, there's probably, again, get into risk versus reward, right? So. All right, there's a lot of information, a lot of words. Go ahead, in the bottom right, circle that. So I want you guys, so we'll go through this, right? And I need you to know that the frontal lobe predominantly controls behavior, emotion, problem solving, personality, reasoning, and it's the primary motor region of the crus central gyrus, right? Yes, I guess you can kind of deviate a little bit and circle Baroque's speech area, because that comes up a little bit. We'll talk about Baroque's and Wernicke's. But Baroque's speech specifically located in the posterior frontal gyrus of the dominant hemisphere, right? And this is destruction of that area is going to cause that Baroque's aphasia. I think you guys may have watched a movie or a clip on that or something. Yeah. Try to like be all slick and show it, and I was like, that's got a cool movie that we saw that freshman year. I'm like, oh damn. All right, so I stopped showing it. So, all right. Temporal lobe, same thing, distilled at the bottom right. Language, hearing, short-term memory, and smell or olfaction, right? So your olfactory nerve is going to go through there. So, and then I would differentiate here. I would also know Wernicke's speech area in the dominant hemisphere, posterior part of the superior gyrus. Destruction results in Wernicke's aphasia, which is, anybody remember? Word salad, Wernicke's, WW, all day, every day, right? That's an easy 2 points in the pain. So. The parietal lobe, asterognosis, hemispatial neglect, inability to copy figures. Anybody know what asterognosis is? Yeah, so you guys are both doing it, right? So if I'm like, what's going on? Yeah, so close your eyes, draw a number, like 3 or something simple, or hand somebody a key and they hold it and they're like, oh, it's a key. Same thing when you reach into your pocket and you grab something, like, oh, I know it's a pen because your brain, your temporal lobe is kicking in and able to delineate that. So. Does that make sense? Cool. All right. Occipital lobe, visual processing, shape and color identification. Why the occipital lobe for visual processing? What do you guys think? Look, that's the way I was made, man. I don't know. What are you looking for? I don't know. I just found it interesting, right? So I always found the way the body is designed. I think there's don't know, maybe you guys disagree, but this is, I'm not getting into philosophy, makers, creationism, like you guys can figure that out on your own, but two things that always bother me. One, the prostate and the urethra going through the prostate. I'm like, who the hell thought of that? That's a bad idea. And two, the eyes go all the way back, desiccate, and go back to the back of the head. Now, the problem with that, I guess it's not, you know, it can be protected, but the elongation of that optic nerve can create some issues. I showed you guys yesterday, pituitary adenoma. Most of my pituitary adenomas will come in with visual concerns because it's pressing on the optic chiasm. But what happens if you fall back and hit the back of your head? Blurry vision, right? So you lose, your vision kind of knocks out a little bit. So I almost think there might be a better way or a better place for it, but guess what? They didn't consult me. Go figure. So. But that's the reason if you guys ever fell backwards, if you did like a PLF, got pushed backwards in combatives, and you see people or get tackled and they hit ass butt first and then go back and hit their head, that's why your vision gets kind of blurry and jarred a little bit. So visual centers are disrupted. Hopefully it just lasts really quick and comes back. Or you get knocked out. You wake up and like, hey man, smelling sauce. You're like, what happened? Right? All right, hemispheric lateralization, right? So usually the left is better at language, speech, calculation. Right, non-dominant, is better at three-dimensional spatial perception, non-verbal ideation, recognition of face, and better at pointing to a stimulus. So, how many people think they're left dominant? How many people think they're right? How many people don't care? Nice. Thank you for participating. So, I don't think it matters. So I think you guys can do it. You don't have time to do this, but you could go and do like a quick test online that's free that'll assess. But I think the studies have shown that none of it really matters. You use both parts of your brain, but most people happen to be left, but dominant. So whatever that's worth. So neurotransmitters. So you guys, some of these are repeats. So acetylcholine. Everybody remember that one? What do you guys remember about it? Yeah, we remember. Move on, dude. Just click the damn slide. So, yeah. So really important for motor function, right? So remember acetylcholine esterase, action potential, all that stuff. We're not going to relive it, but this is going to play an important part in our neurochemistry as well. So it's going to be released by your PNS neurons, some CNS neurons, so it's all over the place in our neuroanatomy. It can be excitatory at some synapses, inhibitory at others. Okay, so dopamine's another one. Active during emotional responses, addictive behavior, pleasurable experiences. So we see decreased dopaminergic activity in Parkinson's disease, okay, and increase in schizophrenia. So we'll talk more about those later, but just kind of introduce that to you guys now. Norepinephrine, right? Most common transmitter of the postganglionic sympathetic neurons, right? I don't know if you guys go over this, the catecholamine hypothesis of mood disorders, but essentially, you guys remember learning about SSRIs and SNRIs? Really? So you probably learned about it. I'm not sure if you knew that's what you were learning about, but essentially, serotonin and norepinephrine work synergistically for mood. So you just gotta be careful with that one. I don't know if you guys went over. Did you talk about any adverse side effects of some of your SNRIs? Yeah. So if you're messing with catecholamines, you can cause heart stuff, palpitations, increased sweating, anxiety. If you're trying to treat somebody for anxiety and you're making their heart jump out of their chest and more anxious, you may want to choose something else. You get a benzo, you get not. Don't do that. I'm just kidding, I joke, haha. All right, serotonin, so it's a permissive serotonin hypothesis, kind of just talked a little bit about it, mood stabilization, and then also use commonly in antidepressants. So. All right, some amino acid transmitters, so GABA, anybody know what GABA stands for? GABA? Nobody? Anybody want to look it up? We move forward. What'd you say? You got it? Yeah, go ahead. Alpha, beta. What? We used to become best friends? Yeah, you don't think I'll do that? Come on, dude. All right. For the rest of you, you gotta look it up. Sorry, you missed it. So, all right. I would like you to know that GABA is the major inhibitory neurotransmitter in the brain. Circle that for me. Most common is major. Those are easy money, right? These are going to be associated with benzodiazepine binding sites. So benzos enhance GABA. So this is inhibitory. Benzos chill you out, and they enhance GABA. Does that make sense? That's confusing for some folks. Because you're enhancing, you're increasing and enhancing inhibitor, which is going to have what effect on you? You're going to bring you down. You're chilling, right? So if you're adding, if you're increasing GABA, you're chilling somebody out. So glycine, the major inhibitory neurotransmitter of the spinal cord. So that's another major one. I'm going to ask you one of those three. Just stay tuned for my review. We'll narrow it down a little bit, but I honestly can't remember which one. So, and then excitatory glutamate. So that's your major excitatory neurotransmitter of the brain, right? So, you guys can see the rest there. So I'm not going to read it out loud to you. What does it matter? So some clinical correlations, which is what you guys are here to do, not rote memorize kind of neurotransmitters just to get 2 points on an exam. So Parkinson's disease, we talked a little bit about, so that's degeneration of dopaminergic neurons, right? And the substantia nigra. Huntington's disease, we'll talk a little bit about these later on, so you don't have to memorize any of this or circle any of this right now. But that's a loss of acetylcholine and GAP-containing neurons. You guys can see the corresponding locations of the brain. Alzheimer's disease and myasthenia gravis, you guys can read those. We talk about each one of those later on, just to kind of expose you to it right briefly. So, cerebral signs. So I would like you to know these, so you can star this one. You'll get a couple questions on these. Symptoms localized to your cerebral function. So higher headquarters we talked about. Aphasia, apraxia, neglect, extinction, frontal lobe, dysfunction, and affect, right? So we'll talk a little bit about these. So aphasia, inability to speak. A deficit in naming, anomia, is the single most common finding in aphasic patients. Circle that. So a deficit in naming, anomia, is the single most common finding in aphasic patients. There's two specific forms. We've hit these a little bit, but Baroques, Barocas, I don't care how you say it, and Wernicke's. Okay, so frontal lobe versus temporal lobe. Doing and sensing, broken versus word salad. So I would like you guys to know this. And I think you've been exposed to it before. So. Depending on how you learn, so I broke them down individually and then I put them side by side, which I think is a little bit more helpful. But so this is your Broca's aphasia, non-fluent, broken speak, right? So contrasted with Wernicke's aphasia, and then to me this kind of makes a little bit more sense. Comparing and contrasting the two. So I would like you to understand, right, what part of the brain is being affected, and what's going on with your patient if they present with either broken thoughts, broken speech, or word salad. Okay. Apraxia, inability to carry out purposeful movements in the absence of paralysis, right? So focal disturbance of planning and doing. Can anybody give an example of like apraxia? Inability to carry out purposeful movements in the absence of paralysis. They're not paralyzed, they're just not doing things because part of their brain's knocked out.
Sleeping?
Yeah, sure. Finger and nose, so they can't do that. What else? What is a purposeful movement that you guys do every day? Walk. What else? Tie your shoe. Stretch. Did you say stretch?
Yeah.
My man, you wake up and you're like, yeah, that's awesome. Oh, I need to do that more. So, yes, so good. Neglect. So this is another cerebral sign. So again, we're talking about insult to the cerebral cortex. And now this is usually secondary from a stroke, which we get into later. But you get a cerebral sign of neglect. So what is neglect? You guys can read through there. So cortical disorder, right frontal or parietal lobes, damage to non-dominant hemisphere, referred to as directed inattention or lack of attention paid to one hemisphere. So again, this is why we have folks draw objects, right? So we'll have them repeat draw objects in the MMSE. You can tell them to draw a clock face, number it 1 through 12, and then they're going to like neglect a part of it. So how could this present with somebody that has a severe disturbance in this part of their brain? forgetting to shave part of their face, forgetting to put one of their arms in their shirts. Like, that would be pretty darn severe. But there are cases out there that has happened. Okay. Okay. All right. A little bit about the basal ganglia moving forward. So 3 nuclei. So you got the globus pallidus, the putamen, and the caudate nucleus. The first 2 form the lentiform nucleus, and altogether the corpus striatum. I don't want you guys to memorize that. You already passed anatomy. I'm not going to ask you questions on it, but just to understand kind of what's going on and what this does, and what insult to this area can kind of manifest as a physical exam on in patients. So, coordinates motor activity. So input from the cerebral cortex, thalamus, and substantia nigra. And you guys can see there, I'm having a really bad GERD attack. That's what I'm doing here. So, damage results in shaking, tremor, muscle rigidity, stiffness, involuntary muscle movements, and then Parkinson's disease and Huntington's disease both this is gonna affect that, right? So the basal ganglia. So I was gonna ask you how could somebody present, but I just gave you the answers. If you're paying attention, to be honest. The diencephalon, thalamus is your major sensory relay, important memory pathways. Okay. Anybody remember other parts of this? The diencephalon. For no points, just a crisp high five. Yeah, what else? Pineal gland? Good. Yeah. All you have to do is look for it. Did you say it, man? Did you say it? Quietly? Still counts. Do me a favor. Did you give him a high five? Yeah, thank you. That was very lazy with me. All right, hypothalamus, master control. You guys just talked about that a little bit. And then the pineal gland, or the epithalamus. Anybody know what that's responsible for? Circadian rhythm, right? Sleep, wake. No points on anything. Anybody remember what pineal stands for? Pine cone. Who got it? Give that man a crisp high five. Yeah. Nice. Where we started here. So. Yeah, pine cone, Latin, I'm not going to ask you that, but people that are having sleep-wake disorder, circadian rhythm, or flipping their circadian rhythm a lot, they may have pineal dysfunction, something to consider. So, limbic system, get a little bit more mapping into your emotional brain, your amygdala, cingulate gyrus, midbrain raphe, locus ceruleus, and hippocampus. Anybody have a favorite out of those? Nobody? What's your favorite, man? I saw it. You nodded. Yeah, you in the back.
I love good midbrain rate.
You do? You're an N of 1, man. You're walking a lonely path. Anybody fan of hippocampus? Yeah? All right. Amygdala's your favorite? Sorry. So, limbic cortex, emotion, eating, reproduction. So you guys can see there, is that important to us? Kind of keeps our species alive. So that's kind of important. So amygdala, so nucleus, nuclei deep in the temporal lobes, chief role in memory and emotional experiences, central role in behavior, response to fear. Some people might have less of a amygdala response, control some of that or suppress some of it. But hippocampus, right? I think I asked you guys this last class, or maybe I said it previously, but Meet the Robinsons, Disney movie. Anybody see that? Yeah, tap the hippocampus. That's why it's my favorite. My genre when my 19 and 16-year-old was like watching cartoons all day, every day, and I'm like, I better get used to this. And if you haven't seen it, it's a cute little flick. But anyways, it's responsible for some of your memory stuff as well. So. NEAT may predict the next event based on what's already happened. Everybody remember deja vu, right? You ever get that deja vu feeling? You walk into somewhere, feel like you've been somewhere, it's already happened to you. It's probably your hippocampus kicking in. So, what do you guys do when that happens? Like, I don't get time to worry about this, right? That's pretty interesting. You're just suppressing your neurochemistry. Good job. All right, breaking 5. Bear with me. I know this is dry, but. We'll do the cerebellum, so small brain, 10% of volume area, 50% of neurons, right? So that's pretty significant. So you got 2 hemispheres, 10 individual lobules, blood supply, superior cerebellar artery, anterior inferior, posterior inferior. Talk about why that matters when you get to stroke. And we'll talk about where most of your cerebellar strokes take place based off just anatomy, to be honest with you. If you think of a subway system, first stop off your subway, for a clot to get off and cause a problem is going to be your posterior inferior cerebellar arteries. All right, sensory perception, coordination, motor control, right? So ataxia, which is that difficulty moving or walking around. So think of like an ataxic gait. So if you've had too many pitchers of margaritas, you've got to stand up and do the killer crossover and fall down, right? Nobody relates to that? No? Neither do I. God, who drinks alcohol? Lame. But that's a way to consider that. So vitamin deficiency, long-term thiamine depletion, stroke, hemorrhagic or ischemic stroke, all those can cause insult to that cerebellar portion and present with ataxia. Okay, that's why we bring it up. There it is, a little bit more. So gross lack of coordination and motor activity. And we just talked about a drunk has an ataxic gait. So, all right, let's take 5 minutes. We'll come back and finish this up. I'm smoking you guys from that. No consideration as to what you guys had to go through before this too, right? What did you have? Infectious disease. Yeah. What you guys learned so far? Like doxy or Cipro? Like, watch this trigger. I don't know, take them both, man.
Because you don't trust them because they're not
There you go. There you go. What are you guys talking about in infectious disease?
plague, HIV,
Gonorrhea.
Yeah, you see some winners there. So, yeah, you see, yeah, you'll see gonorrhea and chlamydia a ton. I had a, so I don't know if I told you guys, my first battalion I went to, 163 at Fort Riley, we led the division in DUIs. Not we, like, I wasn't fine. I had 0, but I think I tell you guys when I first met my boss, he was like, grab a beer. I think I told you that story. And I'm like, is this a test? Like, because I don't trust anybody that won't have a beer with me. And I'm like, all right, game on, man. So, and then every time after that, when I went to talk like med pros, IDES, he'd be like, grab a beer, and him and Sarmate would just sit down and have a single beer. It's legal, don't worry. Everybody's looking at that, and I'm shocked at you. You're looking at me like judgy vibes. And then I found out we led the division in DUIs. He built like a dry bar in his conference room. And I thought I had to tell him, like, hey sir, I think you need to calm down. Like, I think this is a problem. And we also had a ton of GC and chlamydia cases, which I would always tell him, like, he's always asked, like, Doc, what are the common threads? Like, what trends are you seeing? I'm like, sir, we're leading in alcohol consumption and also leading in STIs, and that's not a good thing. That is a bad thing. And he's like, I talk to these kids. This is an old infantry guy. I talk to these kids. I think it's aerosolized down there. Hey, sir, I can tell you right now, like, they're not getting it from toilet seats, and they're not getting it from kissing. Like, if we need to have that talk, we can. And he was like, I want you to give a battalion-wide brief on STIs and scare the shit out of them. So, you guys, that'll be part of your job if you're active duty, go into a unit. And it's good for them, right? Real talk, in that same unit, I had 2 HIV positives. So, same kind of thing. Like, you'll have patients come in. I'm concerned about STIs. Like, I had unprotected sex. No idea who it was. Had a few amber-colored adult beverages. Made some poor choices. And they're like, I just want to be tested for gonorrhea and chlamydia. And I'm like, no, that's not how this game's played. Like, you're getting tested for all of them, right? And then inevitably, if you keep testing for all of them, you're going to find them. Syphilis was making a comeback, which I thought sitting here as a student, I'm like, I'm never going to see this. I see syphilis all the time here, outside, not your population. But I'm like, God dang, like, this is definitely making a comeback. And then I did have 2 active duty soldiers, one that was getting out, it was like their exit physical, another one that we got back from Djibouti. Apparently people were having sex through fences. I didn't know that was a thing. Unbeknownst to me, if people can think of it, they're going to do it. We can talk more offline about the process of notification for that, because that was significant. And you get used to them because we have to do HIV testing, what, every year, twice a year, or every 2 years? So they'll throw your name in as an ordering provider. You're responsible for those orders. So like every time I go work at Moreno now, they're always throwing orders under my name. I'm just like, negative, acknowledge, oh shoot, that's positive. That's not your responsibility or mine to notify. Anyways, I digress. Where was I going with that? No, we talked about what you guys, so plague, I don't think I've seen plague yet. I'll keep my eye out. What else besides STIs and plague, did you say?
Anthrax.
Perhaps smallpox. I saw monkeypox a few times when it was making a surge, and it's kind of died down. I don't really see a lot of ID stuff. Typhus was out there. Typhus kind of ebbs up into the San Antonio area. So, I don't know. It's fun stuff, I guess. It sucks to memorize it all, though. But I remember how that felt. And I did not look at the person and be like, you have typhus. Matter of fact, it's Warren typhus. I just knew this dude was sick, and he was like meeting serious criteria, so he started fluid replenishment antibiotics. Admitted him to the hospitalist. I ruled out everything, flu, COVID, blood, and they were like, oh, he's hyponatremic and his liver enzymes are up. And I'm like, yep. And I CT'd him, there's no obstructive pathology. I have no idea what's going on. He had hepatitis panel, negative. Some dude walks in, some like Dr. House character walks in and comes out, and he's like, are you the PA taking care of him? I'm like, I'm here for my lesson, sir. Like, preach. And he's like, she has dogs at home, fleas. Did you ask that in your history? I'm like, no, sir, I forgot that one. He's like, she has typhus, I guarantee. I'm like, oh, man. And my attending physician was next to me, just like wetting his pants, laughing. Like, you didn't ask about her dogs, bro? Doxy, give her Doxy. All right, back to the brainstem, back to the fun stuff. I know you guys love this, right?
Yes, sir.
Yeah, all right. So we're almost done through our journey through the brain. I think we're moving at a reasonable clip too. So, brainstem, your midbrain pons and medulla. So what is this responsible for? What does your brainstem do? Why are we talking about it? Who cares? Yeah, it keeps you alive. Like all the things that I don't have to think about when to take a breath. Like it just happens, right? Thank God. I'd probably asphyxiate, just die. Same thing, right? So this is a high concentration of myelinated nerve cells, anterior, motor, posterior sensory. All right. There's a couple tracks there. You got your pyramidal track, voluntary movement, extrapyramidal, involuntary movement, posture, adjustments, coordination. So like, why can you stand up and not fall over against gravity? Your brain's helping you out there, specifically your midbrain. So it's the anybody remember what the RAS is? You guys in farm, renin-angiotensin? We're not talking about that one. This is a reticular activation system. So this is like your emotional brain. So I know, like, why do we choose 2 different things? I don't know. So we're talking about brain stuff, not your fluid depletion in your kidneys. So. All right. Kind of a little dry stuff here, but spinal cord, right? Mapping the spinal cord, cylindrical mass of nerve tissue, right? You get the bony vertebral column for protection, right? And it's extension from the medulla, first and second lumbar vertebrae. It's both gray and white matter. You get your nerve cell bodies and then your myelinated nerves, okay? And you guys remember where it terminates, conus medullaris, and turns into the cauda equina, which stands for horse's tail, right? Who cares? Why do we care about that as future clinicians? What is it? I'm deaf, apparently. I am hearing like psycho what?
And site for LPs.
Site for LPs, good, right? So perfect. Yeah, I was waiting for you to say that. You said it, and somehow my brain is damaged, right? So yeah, so it makes sense, common sense, for us to try to induce a needle here if we're trying to do an LP. Instead of sticking into a fat bundle of nerve tissue that's going to hurt your patient and potentially block you from aspirating any CSF, let's go below it where it's fanned out, and if you hit one of those, it's going to kind of glance off of it and maybe cause less trauma, less pain. So 5 segments, right? Cervical, thoracic, lumbar, sacral, coccygeal. Just kind of memorizing those, right? Whatever you got to do, but you guys probably already memorized this stuff. So your motor pathways, upper motor neurons, right? It's extremely long cells from the brain originating down all the way to the spinal cord to where it's going to action with your lower motor neurons, which we'll talk about in a second. So this is kind of important to know when we talk next class about upper and lower motor neuron lesions or damage and how this presents with your patient. So spend a couple minutes with this tonight or whatever when you have to kind of flip through and just refresh your memory. So your upper motor neurons, just taking a look at that diagram there, right? Start at your brain, go all the way down the spinal cord, kind of think of like a subway system, and depending on what you're trying to action or what the action muscle or gland is where it's going to get off and talk to your lower motor neurons, which are right here. So these are going to begin at the anterior horn and carry information to the neuromuscular junction. So again, I move my arm, upper motor, brain to my, what are we going to say? C7, I don't care, whatever we want to say. Then my arm is going to all right, each nerve, if you guys remember this, kind of looks like a butterfly. So we're going to synonymously use the term anterior ventral root. You're going to mean the same thing, and also motor and efferent fibers, right? And then same for your posterior or dorsal root, and then your sensory or afferent fibers. So it's important to understand anterior, dissecting this down, motor, posterior, sensory. And then also that motor and sensory are going to be synonymously referred to as efferent and afferent. I didn't make this up, it's just the way it is. It is a little confusing because you'll see literature kind of jump back and forth and maybe not put them both. I'll try to put them both when I ask you a question on it. So. All right, spinal cord tracts, y'all remember these? There's more, but I would like you to memorize, I would like you to know these 3. When we get to spinal cord injuries, this will make sense. So if you have to put a star, half moon. So cortical spinal tract, responsible for voluntary motor activity. Spinal thalamic tract, pain, temperature, light, crude touch, and pressure. And then posterior or your dorsal columns, fine touch, 2-point discrimination, and proprioception. And this gets important when we talk about spinal cord traumas and assessing somebody, 1, at what level are they losing function, and 2, what function are they losing? Is it motor function only, and they still have temperature, fine touch, 2-point discrim? Is it one or the other? And that'll help us delineate where the problem is, and again, what the problem is. A lot of times we might not be able to snuff out the fine differences, like is it light, crude touch, or is it 2-point discrimination? I don't get too wrapped around the axle with that. But take a look at these when you guys are reviewing these slides tonight, more so than some of the anatomy, because I'm not going to ask you a lot of the hardcore anatomy questions, but these ones are fair game. So. And again, naming the tracks, whoever did it, thank you, right? It helps us a little bit just with the name. That's just a little bit more information for you. So the position of the white matter, where it begins and ends, and the direction of information flow. So it gives you an example. Lateral corticospinal tract, right? Lateral white column begins at the cortex of the brain, ends in the spinal cord, and then it's a motor descending tract. So again, if we know that and know how to dissect the name, we can kind of break down some of that information. Fair? Fair or unfair? Unfair? I don't know. All right, and this is just giving you some of those. So again, if I'm going to flip back really fast for a second, but I do want us to know these 3, corticospinal tract, spinal thalamic, and the posterior columns. And again, I just give you a little bit more information on the corticospinal pathway, the motor pathway. The descending corticospinal tract is also known as the pyramidal tract, terminates at the anterior horn. Stay tuned for kind of more information on again, when we get to spinal injuries, why this is going to be important. Okay, this is going to give us some more information on the posterior columns, where they are in the spinal thalamic tract. Okay, jumping forward, those two are going to be sensory, spinal thalamic tract, sensory fibers, entering across midline immediately, ascend to the thalamus in the spinal thalamic tract on the opposite side. Okay, this is going to be all something you want to look at. I think we talk spinal cord injuries next class, but I'm not 100% sure. And then lastly, the dorsal columns, right? Sensory impulse, ascend the same side as fibers enter the cord, and then they cross midline at the medulla. Okay, so I'm asking you guys to look at the 1 motor, 2 sensory tracts, and just refresh on the anatomy. So a little bit more of a reflex arc. You guys are going to be doing reflexes downstairs. You've been doing them. We talked about them last semester. Just a little bit more information on them. Okay, so understanding kind of how this works will help you guys understand or snuff out some pathology. Okay. So I don't care if we're looking at this picture. You know, hold your hand over a flame if you need to, if that's what you do, or stab yourself with a tack. Hit yourself with a reflex hammer. It probably makes a little bit more sense. I would bring a lighter and just start lighting the patients on fire. That's not a good idea. But understanding that when you do that, they have a sensory receptor, sensory neuron, right, that's going to jump from where they're receiving that information back into the spinal tract here. This part is extremely important. This inner neuron is going to be extremely important. I know I'm neglecting you guys again. I apologize. Maybe I'm left brain dominant, so I just pulled to the left.
What side of the camera?
So all we're really talking about is this part here, this inner neuron with your reflexes. So when you guys tap someone's patella reflex, this is what's causing them. This inner neuron is to have a result. So otherwise, when you're sitting there and you're downstairs and you're doing your reflexes and nothing's happening, you're suppressing this, and it's going all the way up to your brain, and you're not doing anything. That's when I see you guys do. That's when I see this. Get this shit over with, right? But it's going to be important when you guys assess somebody that was in a trauma and they lost that reflex. Okay, if they lost that reflex, they may have a upper or a lower motor neuron injury. Okay, so something to think about. So. And this is just dissecting that pathway for you guys and understanding how that inner neuron plays out. Okay, so. A little bit of spinal cord review. I'm going to push. I'm not going to say much about this, but everything we just talked about with the 3 tracks I want you guys to know. This is just summarizing it, so maybe a good slide for you guys to look over tonight. Blood flow, again, back to some more anatomy. I know I'm killing you guys with this, but this is going to get important when we talk about stroke specifically. So arterial supply, you guys can see there, our trip off the aorta. Common carotid, internal carotid, anterior communicating, right? You guys can see the different stops there on the subway system up to the brain. And this is going to be important, again, when we talk about stroke pathology and some of the coronary artery disease or atherosclerosis from the heart. Who's beeping? Is that a pager? You have a pager? That is very 1990s. So, nice. Circle of Willis. So again, circumferential anatomy, this is going to be important when we talk about aneurysms specifically. Ruptured aneurysms, berry aneurysms. So this is kind of a neat anatomy area, anatomical area where you have like circumferential arterial supply from your anterior, posterior, cerebral, and communicating arteries. But really clinically relevant is when we start looking at stroke and disruption of this from unchecked, usually hypertension. We start bowing out or breaking some of these vessels or popping them. That can be very problematic for your patient. Unfortunately, that's going to kill them if we don't identify it and treat it rather quickly. So. Posterior circ, a little bit I talked about this earlier, but you can see there, I think I alluded to it as a subway system, but if you follow inferiorly, if you go that picture to your right and you look down, your really first bifurcation or stop off that is your PICA, your posterior inferior cerebellar artery. So typically if you're gonna see a cerebellar insult, stroke, ischemic, hemorrhagic, I don't care, it's going to be there. It's going to be in the PICA. Could be somewhere else. Somehow it could matriculate past that. But and again, kind of putting things together here. If I did have an insult to my cerebellum, what symptoms may I be demonstrating to you as a clinician? Ataxia, right? What else?
Motor coordination.
Motor coordination, right? So yeah, this is why we do all those things downstairs. That's why I want you guys to start putting that stuff together as opposed to just be like, this is a stupid picture. I hate it. I hate all your slides. Like, I want them to all get burned. I felt the same way. But start putting this stuff together. And then I can kind of convolute a little bit for you. Like, I've had patients don't always read the textbooks. I need you guys to start thinking in almost like a black and white world right now that this, if they're having a cerebellar insult, they're going to manifest with those symptoms, right? They're not going to be able to walk. They're not going to be able to feel the shift. They're not going to be able to finger the nose. Because you guys need to kind of correlate that clinically. I've had guys come in that have had PICA strokes, and I've gone back, and I'm like, they're like, oh yeah, they're having a stroke. PICA is totally occluded, and I've gone back, and I'm like, let me test this stuff out. Because I have to stand up and tell very smart people that this is what we're looking for, and the dude's just rocking and rolling. I'm like, stop it. I'm like, do this one then. He's like, just, well, why do you want me to do this? And I'm like, no reason. Like, we're going to take a trip. You're going to go see the neurosurgeon. Like, but I walked him too. Like, I was like, really? Did I miss this? I've gone backwards and reverse engineered it. And I'm like, no, man, I walked him, heel to toe. I've done dysdiadochokinesia. They've done fine. And they were just able to compensate with it. Interesting, I think. But sometimes you got to worry about chronic disease pathology. So some of these folks are so neglected, right? I don't know this specific guy. I'm free copping on you, go figure. But maybe they're chronic drug abusers or alcohol abusers that their body's compensating. So somebody like anybody in this room had an insult to your PICA or your cerebellar portion of your brain, you're gonna know it. Like, you're gonna see it fast. You guys are all extremely healthy individuals. Some of the folks I see, like, I go back and do some of the tests, and I'm like, do pronator drift, and they're rocking and rolling. I'm like, this just doesn't make sense to me. And it's frustrating a little bit, but okay. Sorry to rain on my parade. All right, meninges covering, right? So we have the duramator, arachnoid, and pia mater. So these are going to be important when we talk about meningitis a little bit later. But knowing the outermost is the dura, arachnoid lies above the subarachnoid space. And then pia, the delicate inner layer that covers the brain. These are pretty cool if you guys get to do any type of neurosurge rotation. You'll see some of this stuff. If they have to do any type of evacuation of clots, they get to peel this stuff back, which is pretty cool. I think it's neat. I told you guys my wife is a neuro ICU nurse. Like, she geeks out over this stuff. Like, seeing somebody drill in someone's head isn't my favorite thing to do, but it's pretty cool. So I think if you get to see it, do it. All right, the dura is going to extend all the way through the CNS, so it's going to protect the spinal cord, right, all the way down. You guys can see that there. CSF fluid, right, we know this, surrounds the brain, spinal cord, clear, colorless, few cells, little protein. That's going to matter when we start talking about somebody that's really sick and has meningitis. And we're going to try to delineate bacterial versus viral. I know you guys have done some of those CNF pseudo-analysis. I'll tell you now, I'll probably ask you a question or two. But in the grand scheme of things, if you're thinking someone has meningitis because they have headache, buccal rigidity, and fever, and you guys tap them, like, it's going to come back and give you the answer. So you don't have to freak out and, like, let's try to isolate you. Like, oh, everybody's irrelevant around you. Like, they'll call you and tell you, like, yeah, patient has bacterial meningitis. Like, what antibiotics did you give? And you guys will coordinate that. So medicine is a team sport, if I've said that before. So. No points on anything. Anybody know how much CSF is floating around in your head? $40, $60?
Multiple milliliters.
Multiple what?
Multiple milliliters.
Multiple mLs. So it's like 150. Circulates every couple hours. Like, yeah. So I think so. You say, like, well, it's mildly relevant, highly interesting. So it gets important when we talk about pseudotumor cerebri or some pathology a little bit later. So you can start developing too much CSF, creating pressure in the head, and some of the therapeutic treatments is just removing some of it, right? So if they come to you and you see it, you can try to remove some of it if you're tapping them. You may do a spinal tap and you're like, wow, I feel a little bit better. And you're like, wow, that's a pertinent positive. That may be pseudotumor cerebri. But ultimately, they're going to need like a VP shunt or a shunt to drain that off, and that's going to be neurosurgery for that. So, again, your ventricles, so that CSF is going to kind of originate and turn over. So you get your 2 lap vents, 3rd and 4th. Again, we'll look at some pretty CT scans and show some shifting, or midline shift of those ventricles and some things that we look at. So that last neural tube defect, encephalocele, so that's an anterior pore defect. It's the least common of the 3. Okay, and you guys can see the picture of the baby there, so that's forming outside, suboptimal for them. So again, I put this in the end because you talk about what can you guys do to try to prevent that. Does anybody remember? Folic acid for your low risk patients. 0.4 for high risk patients. 4 milligrams. What delineates a high risk patient? Good, good. And then when do you want to start them on folic acid supplementation? Excellent. All right, it was a long journey. We're almost there. I know, you're like, damn, we're going to go through all that. All right, autonomic nervous system. Anybody tell me what this does in their own words? Or you can read it.
Keeps you alive.
Keeps you alive? Yeah. It automatically regulates your systems. Yeah. So you can see there, it's going to regulate glands, smooth muscle, cardiac muscle. This is going to be your fight or flight. So you guys see there, sympathetic, fight, fibers exit, T1 to L2. Parasympathetic, rest and digest, right? So you see there just some more information. So thank God we don't have to think about this, right? It happens. So your body, your bladder's filling up slowly as we talk about it. Your stomach is doing things. All your internal organs are harmoniously working, and it's all because of this. We're not thinking about it. So. We're almost there. One more slide. I'll just be annoying if I do that. What do you guys got? Very dry, I get it, but we got to kind of floss through some of that stuff and talk about some of the anatomy. So now we kind of move, pivot, and shift and talk about a lot of pathology, which is what you guys are here for. If it's not making sense and you're like, what the heck, what are we talking about? This is going to be a good baseline to go back to, right? So I say fortunately or unfortunately, depending on what your thoughts are on anatomy and physiology, any pathology that you guys see out there, you want to go back to that and kind of look at like, what is this and how should this be working and why isn't it working correctly? So, what's for lunch? Oh, you guys have a lunch and learn. Did you know that? I didn't know that. Ultrasound. Anyways, I got nothing else for you. They're yours.
I gotta walk my dog. I cannot leave her home for 12 hours. She's too much of a diva for that. She is.
Toilet paper cookies. Yes. Yes.
Good to have a dog.
You know they are. They for sure.
It's hard. Like I pay for